So here's our agenda for our 90-minute session today. So first, I'm going to tell you a bit more about the ASXL Rare Research Endowment Foundation, the resources that we have available for families, and how we help connect the professional community. We have a special guest from one of our partner organizations, the Bohring-Opitz Syndrome Foundation, who will share some information about the support that they provide to families. Then we'll hear from our two expert speakers, Dr. Bianca Russell and Dr. Wen-Hann Tan, both of whom are medical doctors and researchers. They are going to share some information about Bohring-Opitz syndrome by taking lots of questions that you all have submitted in advance. So we'll start with those questions that you submitted when you registered, and if we have time, we can take some live questions at the end. So the ASXL Rare Research Endowment Foundation was founded by a parent in 2018 to focus on research. Today, we're led by a team of volunteers who are family members, doctors, and researchers, a highly motivated team of people who are directly impacted by ASXL disorders. At the end of today's session, I'll share a few ways that you can get involved with our organization. So our goal as an organization is to advance our understanding of the ASXL genes, how they work and what they do, and how to improve the care of people who live with an ASXL syndrome. Our mission encompasses the study of the three ASXL syndromes: ASXL1, Bohring-Opitz syndrome, ASXL2, Shashipena syndrome, and ASXL3, Bainbridge-Roper syndrome. These genes and syndromes are unique, but they have a lot in common. What we learn about one of them can benefit our universal knowledge of the other two, and the rising tide of knowledge benefits everyone affected by an ASXL disorder. We are excited and hopeful to return to an in-person ASXL Family Conference next year in July 2022 in Los Angeles, California. This conference is a great opportunity to meet other families, talk to researchers, and learn from the world's foremost clinical experts. We will announce the specific date when it's been confirmed, and we hope to see you in California next year. We also offer a resource library on our website for families that includes recordings of past conferences and articles. The resource library is where the recording of today's session will live. And one of our strategic priorities for this year is to build that library. So please stay tuned for future sessions with medical professionals and researchers. And in fact, I'm pleased to share that we have a new webinar coming up with Dr. Rosanna Wexberg, who is a clinician scientist at the Hospital for Sick Kids in Toronto. She received an R Foundation research grant to study genetic aspects of ASXL1 and ASXL3. Dr. Wexberg will share an update on her research and then take questions from families on Thursday, September 23rd at 12 p.m. US Eastern Time. This is a session intended for families, so her presentation will be in simplified terms that you can understand, even if you're not a scientist or doctor yourself. Another resource that I'll mention that's not managed by the R Foundation, but it's too important not to share in case you haven't found it yet. The Bohring-Opitz Syndrome Support Group on Facebook is a wonderful source of connection and information about life with Bohring-Opitz syndrome. One of the first families to receive a Bohring-Opitz syndrome diagnosis created this support group, and there are currently 585 members there. And then another wonderful source of family support is the Bohring-Opitz Syndrome Foundation. And I'm going to have Anita from the BOSS Foundation come join us now to share a little bit of information about the BOSS Foundation. Take it away, Anita.
Hello, everyone. First of all, thank you, AARE, for having me here today and having this event. It's so wonderful for everybody to be able to connect, especially with the past year and a half that we have had. As you can see, I'm here to represent the Bohring-Opitz Syndrome Foundation. I'm going to quickly describe the foundation and then highlight some really important opportunities that the families should keep their eyes out for and take advantage of. The Bohring-Opitz Syndrome Foundation is a separate organization founded in 2015 by two awesome parents, Carrie Hunsaker and Taylor Gergenis. My name is Anita Ross, as Amanda had mentioned, and I became the chair in 2018. We're a very similar organization, a small nonprofit organization. We're all volunteers and we're really dedicated to helping improve the quality of life of our families and individuals living with BOS and everything that encompasses. You may be familiar with us from Facebook, or maybe you got the matching t-shirt that we have every year for Awareness Day. Maybe you've attended one of the cherished in-person meetup events, which are every year, typically the last Saturday in July. We've had one in California and PA. We actually had 17 families at one, which is such a beautiful and amazing opportunity and event. And we're looking forward to collaborating in the future as organizations to make this an awesome and accessible experience for everybody. The two important resources that I really want to emphasize today for our families here is the Mini Meetup International Grant. This is an opportunity for you to apply to have financial assistance to host your own miniature meetup in-person event, you know, in your country, and you can utilize that. I apologize, I have a dog. You can utilize that funding to either rent a space or have a picnic. The second opportunity that I would like to emphasize is the Family Financial Scholarship Program.
Best laid plans, Anita, right? With the dog.
I just gave them is the Financial Family Scholarship Program, which is an opportunity for you to apply to have expenses covered that typically families don't get covered by insurance, including but not limited to a small home modification, communication device, seat cushions, Firefly products, anything that would benefit your individual living with BOS and your family. I apologize about the dogs. I had the treats on hand for that emergency, so it was covered. Thank you. But basically, keep your eyes open for these. They typically open around February and March. You can find all the information on the website. You know, we love you guys. We love ARRE. We're here for our families, and we hope to make a difference in your life in some way by these resources. So I encourage you to look on the website, reach out to me. Not only do I represent the foundation, but, you know, I'm an occupational therapist and a sibling myself to someone with BOS. So reach out with questions and any support that you need. Thank you again, everyone, for having me here. And this is amazing. I'm excited to be participating in this event.
Awesome. Thanks, Anita. And demonstrating always the flexibility and preparedness of a family member living with someone with Bohring-Opitz Syndrome.
Teresa, we're ready to go. Thank you.
Thank you. Thanks, Anita. Excellent. All right. So next, I'm just going to talk a little bit about some of the services that we provide that help connect the research community and healthcare community. So the R Foundation also serves as a point of connection for the medical and research community, both to each other and to families. We host the ASXL Professional Network, which is a growing network of doctors, researchers, and other healthcare providers who treat individuals with ASXL syndromes. Our goal is to help these professionals talk to and learn from each other. We also help fund the ASXL Patient Registry, which is like a library of data and biological samples from families with an ASXL disorder. This registry is hosted at the University of California, Los Angeles, and data is available for free to any researcher who would like to use it. The R Foundation encourages families to join the registry to give researchers the information and biological samples they need. And I'll talk a little bit more about this in a few minutes, and then Dr. Russell will also speak about it in her part of the session as well. We also fund research grants to advance the study of ASXL disorders. 5 scientists from around the world are currently studying ASXL syndromes with grants that we've provided. Our research commitments currently total $550,000. You can read more about these studies on our website if you'd like to read more. And we also host an annual ASXL Research Symposium to provide doctors and researchers with an opportunity to speak directly to each other, to exchange ideas and develop collaborations. This year's symposium will be held virtually in November, and we look forward to an in-person ASXL Research Symposium held in tandem with the Family Conference next July in Los Angeles. The in-person events are so special because scientists get to meet families who live what they study. Many scientists report feeling a renewed energy to continue their study after meeting families. So I mentioned the registry, and I want to speak a little bit more about that. There's a really strong research interest in collecting samples and data from families with Bohring-Opitz syndrome. You can learn more about the registry on our website or by emailing the research coordinator at UCLA directly, and that's the email address there on the screen. The registry includes a questionnaire, and there's also a biobank to collect blood or skin samples, and families from anywhere in the world are able to join the registry. Dr. Russell, who's one of our speakers, leads this registry, and she'll share a little bit more about it as well. So we're eager to welcome your involvement with the R Foundation. We are funded entirely by families and organizations with a connection to an ASXL syndrome. When you make a donation to the R Foundation, you're helping to advance the understanding of ASXL syndromes and supporting families through education. And there are a couple of easy ways that you can contribute. You can host a fundraiser to benefit the R Foundation on Facebook or in your community. If you shop on Amazon, you can select us as your beneficiary of the Amazon Smile program. And you can also include us in your family's charitable giving by making a donation directly. We also have a growing monthly donation program called the Sustainers Circle. We also rely on volunteers to bring our programs and operations to life. We are seeking volunteers to help supplement our professional services, including IT infrastructure and support, legal advice, accounting, and communications. We're also looking for program volunteers to help run our research grant program, plan our conference, and build our calendar of educational programming for families. And you can visit the Get Involved section of our website to learn more, or that's my email address there. Please email me anytime, amanda@ourfoundation.org. So before I introduce our speakers, I'm going to share a poll here for families, and just to get a sense of who's with us here on the line. So if you can answer these two questions, if you're a family member. So how old is your loved one with Bohring-Opitz syndrome? And how long has your loved one had a diagnosis of Bohring-Opitz syndrome? And if these don't apply to you, there's a not applicable option. If you'd still like to participate, you can select that option. All right, that's most of our attendees here answering. All right, I'll end the poll and share our results so we can see. So the majority of our attendees have a loved one who's in the 5 to 18-year-old range, with additional folks in the 2 to 5-year-old range, one little guy in the 0 to 2, and then 2 who are older than 18. And as far as time of diagnosis, the majority have had a diagnosis for 2 to 5 years. And next up, folks who've had a diagnosis longer than 5 years. So thanks for sharing some of that information. Hopefully that will help give our speakers a better sense of who's on the line. All right, so now I'm going to introduce our speakers who are each experts in Bohring-Opitz syndrome. Bianca Russell is a clinical geneticist at the University of California, Los Angeles, who sees patients with metabolic and genetic conditions. She has been following patients with ASXL-related disorders since 2013 and has made ASXL disorders the research focus of her career. She started the ASXL patient registry when she was a resident at Cincinnati Children's and expanded it to include a biobank when she transitioned to UCLA. Dr. Wen-Hann Tan is a clinical geneticist at Boston Children's Hospital with an interest in diagnosis and management of rare genetic syndromes, including pediatric cancer predisposition syndromes, vascular malformations, and other unusual clinical findings. He has also been actively involved in a longitudinal natural history study and various clinical trials in Angelman syndrome, which is another rare neurodevelopmental disorder. So we're going to start now with questions that have been submitted in advance. I will ask them of our speakers. If you have additional questions as we go along, you're welcome to put them in the Q&A box and we'll get to them towards the end if we have time. So the question that we are going to start with is a question which I think sort of is a good launching off point, and that is, what is your advice, Dr. Russell and Dr. Tan, for newly diagnosed families? How can a family best support their loved one with Bohring-Opitz syndrome and improve their quality of life?
I can start. So I think one of the things that's most important when you really are hit with the first diagnosis is to take some time, allow yourself some time to process this. So I don't know of any family that goes into planning a pregnancy expecting to have a child with Bohring-Opitz syndrome. In fact, I don't know of many families who go into a pregnancy even knowing what Bohring-Opitz syndrome is. So it's really important that during that initial time of getting a diagnosis that you give yourself and your loved one some time to process, to learn about the condition, and to adjust what is a different normal than what you may have expected when you started out. And when you go through that journey, everyone goes through it a little bit differently. So it's important that you support all the family members and appreciate that everyone may be processing things at their own pace and in their own way. I think we've got some really important resources out there, which Amanda and Anita have gone through a little bit of today. So I think many families can find support in reaching out to other families who've been through an initial diagnostic process as well, and try and find your people and the people that support you and connect with you and can teach you more about Bohring-Opitz syndrome and sort of some things to expect in the future as well. So I think that's sort of the initial sort of well-being of the family and the processing part of things. It's also important then to find a medical team that you connect with, that you think can support you and your child through this process, and is someone you can talk to, you can relate to, and that has your child's best interests at heart. And it doesn't have to be someone who's the world's expert on Bohring-Opitz syndrome. It just needs to be someone who is interested and committed to you and your family and wants to learn and is willing to help you connect to the right people on this journey. And then I think learning to be an advocate for your child is incredibly important. I think talking to Bohring-Opitz syndrome families, I think everyone will tell you that this journey has involved learning how to advocate for your child in a way that you didn't even know you were able to do at the beginning. So being able to sort of learn how to do that is really important. And then overall, I think that it's important that you find care providers that don't put a limit on what your child can achieve. You take any child at any age and you ask any doctor or any person in the world, what will my child do? What is my child's potential? Will they be Shakespeare? Will they be able to be in the Olympics, right? Nobody can answer any of those questions for you. And so it's really important that you find a team that recognizes that and doesn't put a cap on what your child can achieve. And from there, I think one of the most important things that sometimes gets pushed aside is making sure that your child has access to therapies, things like feeding therapy, occupational therapy, speech therapy, things that can really help support their mobility and their access. OT is also really, really important in helping make sure that they have the tools to continue to grow and develop to their maximum potential. So there's the medical side, the raw medical side of how do you treat an organ that maybe isn't doing what it's supposed to be doing, but there's so much more from the therapeutic side that's really, really important that your child gets connected, and you may have to advocate pretty hard for that, but that's really an important part of your child's care.
So I agree with what everything that Dr. Russell has said. I think that's very well said. I would add a few things to that. One, I think, is, as Dr. Russell had sort of alluded to, really acknowledge that this is a different journey from what you had anticipated, but it is equally rewarding, just in a different way. And I think it is important to sort of take the time to really absorb that and recognize that this is not what you had signed up for initially. I think on that note, I also tell parents that it is really important that you take some time for yourself. If you can arrange for childcare, if you can arrange for someone to take care of your child, you should have date nights. Go out between yourselves. I think preserving the couple relationship is really important because you're going to need this as you move forward. So building the social support that you will need, whether it be through friends, neighbors, relatives, or whoever, that's really important. I think it is also important to recognize that every child is different, every child is unique. And what I often tell parents, and this is not unique to Bohring-Opitz syndrome, but really to all genetic conditions, is that if you look at the internet or textbook on a particular syndrome, you will see a very long list of symptoms, manifestations associated with that syndrome. We do not expect any child with a given syndrome to have all of those symptoms, but we do expect every child with that symptom to have at least some of those symptoms, because otherwise you don't have the syndrome. So it is important to remember that there is variability in the spectrum and in the severity, and your child is unique. And it's important not to sort of scare yourself and say, oh my God, I've read this on the internet, my child is going to have all these manifestations. No, not necessarily. I think sometimes as doctors, when we tell you about the potential complications, It is just that these are potential things that you need to sort of just be aware of, that maybe your doctors need to be aware of, but they may never happen to your child. The last thing I would say is it's also really important to remember that this is not your fault. It is not anyone's fault. Mothers are born to feel guilty, and all mothers and parents feel guilty about having a child with a genetic condition. There's really no reason to do that. And you need to make sure that other people do not make you feel guilty. So it is not something that you did or didn't do during a pregnancy, not because of any X-ray machine you walked past, any radiation you had, any soda you drank, any detergent you used. These things happen. All of us carry mutations, every single person on this earth. And in fact, all of us carry tens of thousands of mutations. But fortunately, most of these mutations do not cause us any harm. They do not affect genes that result in a known human genetic condition. But unfortunately, in a very small proportion of individuals, it just so happens by chance that a mutation hits a gene that results in a condition. So I think, it takes time, and I think it takes time for you to work through that guilt, to acknowledge it, and then to recognize that this really is not your fault. It is not something you could have prevented or predicted. And I sometimes tell families that even if you had come to me before you were pregnant, that you wanted a child with Bohring-Opitz syndrome, I could not have made it happen, right? So this is something that just happened. So those are the sort of things that I would add to, I think what Dr. Russell had told you, which was all really important.
Thank you to you both. So the next question is sort of an extension of what you were saying, Dr. Tan, about the different potential symptoms and manifestations. And this is more of the why question. So we hear in the family support group and other places, families wondering, why is there such a big variability between people with Bohring-Opitz syndrome in terms of some of their abilities and their symptoms? So what causes that difference?
So the simple answer is that we do not know. We see this in practically all genetic syndromes. So and I often like to use Down syndrome as an example because that's pretty well known worldwide. So if you look at Down syndrome, for example, they all have 3 copies of chromosome 21 by definition. But some of them are pretty capable, and we have seen Down syndrome adults who live independently. They graduated from college, they hold down a job, and yes, they have some struggles every now and again with certain things, but generally they function well. And then there are some Down syndrome individuals who are more severely affected and are unable to take care of themselves, such as in institutions or group homes, etc. So, and they all have the same underlying genetic abnormality. Same thing with Bohring-Opitz syndrome, with any other condition. There is a spectrum. There are thoughts about different types of mutations affecting the amount of protein produced that may contribute to that. So at a genetic level, there are hypotheses for why some changes may be more severely affected, and other changes result in a less severely affected individual. But at some level, it doesn't really matter, because the other thing to remember is that Bohring-Opitz syndrome affects multiple organ systems, as you know, right? So affects the eye, some individuals have cleft palate, cleft lip, some individuals have problems with their heart, some individuals have problems with their feeding. It's not uncommon for an individual to have mild manifestations or even no manifestations in some organ systems, but more severe manifestations in other organ systems. So there are differences. Remember that each of us has about 20,000 genes, and all the other genes contribute to our functionings. ASXL1 is really just one of the 20,000 genes that we have. So it is possible that there are interactions with other genes, functions of other genes that also contribute to the spectrum of severity that we see.
Thank you. Next question will be for Dr. Russell. If a child hasn't had issues with feedings or seizures so far, does that mean they won't develop in the future?
This is a really good question. So we'll tackle the feeding part first. The majority of children who have feeding issues with Bohring-Opitz syndrome present with feeding issues early on in life, in infancy typically. And we do notice a general pattern that the feeding issues tend to improve, if not resolve, as the child gets older. So it tends to be a more significant problem in the first 5 or so years of life, and then it improves over age, with age and over time. That doesn't mean that somebody couldn't develop a feeding issue later in life from all sorts of different things, but the typical pattern is feeding issues early on that stabilize or improve as they reach childhood age. For that reason, I do always really encourage families that even if your child has a quite significant feeding issue as an infant and needs a G-tube, which is very common, still do what you can to safely work on oral feeding skills, because it's possible that your child may really enjoy feeding by mouth later in life. It's always important to make sure that they're safe to feed by mouth and that they're not aspirating so that whatever they're eating isn't going into their lungs. But it is something that if it's safe for you to do, that can be a really important thing to continue to develop, as it's something that's quite enjoyable for all of us to eat. We all love to eat. So if that's something that you can work on with your child, keeping those skills up can be really important. In regards to the seizures, we see all sorts of different kinds of seizures presenting at all sorts of different times. So what I typically tell families is that individuals with Bohring-Opitz syndrome have a lower threshold for seizures than maybe a neurotypical individual. So I think of it this way, right? So we all have a potential to have a seizure at some point in our life. The majority of us, our threshold is up here. So you have to have a lot of things happen to you before you ever develop a seizure. So most of us don't ever develop seizures. Somebody with Bohring-Opitz syndrome, their threshold may be a little bit lower. So it may be down here. And it's possible that they never get to a point of things adding up in their life to pass this threshold, but it is also possible that they do. And because their threshold is lower than a neurotypical person, they're always at more increased risk. So it is something that is important to sort of keep on the radar and be aware of a risk in your child's life. But it is also true that as they get older, and if they've never developed seizures, it is possible that they also may never pass that threshold and they never develop seizures.
Thank you. Next question is also for Dr. Russell. Could you speak a little bit about internal organs? So, Bohring-Opitz syndrome families are screening their children for Wilm's tumor. And the question is, are there other challenges with internal organs that you're aware of aside from Wilm's tumor? And do you have any known causes of abdominal pain?
Yeah, there's a lot to unpack in that question, but another really good one. So I'm going to take a second to talk about Wilm's tumor and the surveillance that we recommend. And so Wilm's tumor is a tumor that typically presents in children, even in individuals who don't have Bohring-Opitz syndrome. The risk for Wilm's tumor is a risk that happens in the first 7 years of life. So it is very, very, very uncommon to have a Wilm's tumor after the first 7 years of life. So the surveillance involves ultrasounds primarily in those first 7 years. After those 7 years, the risk for Wilm's tumor is way, 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 way low, and we don't do any surveillance after age 7. So I think it's important to recognize that. The other tumor that has come up is we do know of one individual who had hepatoblastoma, which is a tumor of the liver, and also sometimes runs together with Wilm's tumors in that we oftentimes see Groups of people who are at risk of Wilm's tumor are also at risk of hepatoblastoma. It's again something that you can see on ultrasound. So by ultrasound and looking at the kidneys, an abdominal ultrasound will also look at the liver. So you can at least get some sort of surveillance that way. If it's something you're worried about, though, we've only had one individual, so we've not risen to the level of recommending specific screening for hepatoblastoma. But hepatoblastoma is sort of like Wilm's tumor, are a pediatric tumor with the risk being very minimal or resolved sort of at age 4. So again, it's something that if there's surveillance recommended, it's in those first couple of years of life. Okay, so I think it's important to recognize that. When it comes to, I'll sort of pick off the GI issues or the gastrointestinal issues, since that seems to be a main point of this question. Of other things that we do see that can cause abdominal pain, the most common is absolutely going to be constipation. And I believe there's another question later. Well, we may talk about that more, but majority of the time it's constipation. Constipation causes a lot of pain and discomfort. And in an individual who may not be able to express that and tell you what's happening, that can be quite significant. So constipation is always the first thing on our mind. Other things that are more rare but are possible, we do have a report of some individuals having what's called a malrotation. So the gut actually twists, and in that twisting, it can be blocked. We don't see it all that commonly, but it is something out there. So if there is sort of a sudden onset of abdominal pain that's out of proportion, it would be reasonable to seek medical attention and make sure that there's not a blockage in the intestinal tract, such as a rotation of the gut. We also see patients with kidney stones and gallstones. Those can sometimes cause pain, but a lot of times we find them sort of incidentally, but it is something to keep on the radar and be aware of if you're pursuing and trying to understand why an individual is having some pain. When it comes to other solid organs, I typically do at least one ultrasound of the heart at diagnosis and make sure that there's no anatomy changes to the heart. Those would be things that someone would be born with, not something that they develop over time. The other one that often gets imaged is the brain as your sort of master solid organ. And my party line with looking at the brain is it's really, really, really important to remember that anatomy does not equate to function. So the appearance of the brain on a picture, which is what brain imaging is, does not equal what the function of that brain is or the potential of that brain. So it can be common to find changes in the brain in people with Bohring-Opitz syndrome, but that does not correlate or connect to how they actually will function in life. So I would say when you interpret any brain findings on your child, do it with a grain of salt, because it's certainly not going to be predictive of how they do in life. It may be more information and something to follow and understand your child, but it's really important to remember that. So those are what I have for sort of solid organs and sort of the gastrointestinal issues.
So can I just add, with regard to brain imaging, as Dr. Russell pointed out, whatever you see on brain imaging does not predict function in any way. Brain imaging in most children require sedation or general anesthesia. So unless there is a medical reason to image someone's brain and to do a brain MRI, I do not routinely recommend that because I do not see how that would add to the medical management. Now, if someone is worried about some other potentially treatable structural brain abnormality. So the most common symptom I can think of in a child is seizures affecting one side of the body, for example. And you're worried, and this is completely unrelated to Bohring-Opitz syndrome. But if someone is worried about, a brain tumor or lesion or some sort of infection or something, then there's a reason to do a brain MRI. But if your child has seizures that are generally affecting both sides of the body or has always had seizures and you have no reason to think on EEG that this is due to a particular lesion in the brain, there's really no reason to put your child through general anesthesia or sedation just for a brain MRI.
Thank you. Okay, next question is going to go back to Dr. Russell. So we know that individuals with Bohring-Opitz syndrome can be very sensitive to medications. What advice do you have for medication management?
Yeah, this comes up quite frequently. And my message to families is that your child is unique, as Dr. Tan had already mentioned at one point, and it's not unreasonable to expect that your child may respond to medications differently than neurotypical children or even than other children in your family, particularly medications that impact the brain. So sedative medications, even things like Benadryl, things that really can change somebody's mental status in any way. Our patients tend to be exquisitely sensitive. So what I often recommend is that if you are going to try any of those types of medications that impact the brain, it's reasonable to start at a fraction of the typical dose. So a fourth of the normal dose or a half of the normal dose, and see how your child does. If they respond as expected, then fantastic, you don't even have to increase it. If they need more, then you can increase it from there. But it is not uncommon that we see individuals responding atypically, needing less dose than typical children, or at a higher dose having what we call paradoxical responses, meaning you have the opposite effect. So Benadryl is the classic one where you think that you give your child Benadryl because they got a bee sting and they're going to sleep all afternoon and they're bouncing off the walls and you can't get them to sit still. That's what we would call a paradoxical response. And so that is something that is commonly reported amongst the families that I've taken care of. So I often try medications at a smaller starting dose and then go up as tolerated.
Thank you, that's great advice. So next question for Dr. Tan. Many families struggle with feeding and constipation. What advice do you have for managing chronic constipation? And do you have any additional advice on nutrition?
All right, thank you. So I'm going to take the second part of that question first on nutrition. So I think it is important to remember that most kids with Bohring-Opitz syndrome are genetically programmed to be small. And it's just that by the very nature of having Bohring-Opitz syndrome, there is some degree of physical linear growth restriction, meaning that they are not going to be as tall as they might otherwise be. What I tell parents is that what is important to focus on is not the weight of your child, but the weight for length in the younger children and body mass index in older children and adults. What you want to do is to maintain a normal weight for length or body mass index, not necessarily to have a weight that is so-called on the curve, right? So if the length of your or height of your child is way below the curve, if you should expect the weight to be proportionately low, because if the weight is actually even close to the curve, your child would actually be obese and you would have all the complications of obesity. So I think it is really important to sort of remember to focus on weight for length or body mass index, and to think about rate of increase. So there's a concept called Z-score, which is basically standard deviation, meaning how far below the average your child is compared to the general population, general kid of his or her age. And what is important is to track over time to make sure that that Z-score remains more or less in the same range. If that Z-score starts to get less and less negative, meaning bigger number, then your child is actually gaining weight at a rate that is greater than would be expected. So that is my sort of suggestion on weight and on nutrition. Coming back to the constipation question, I think this is not something unique to Bohring-Opitz syndrome. It is a challenge, and it is probably a result of the nerve cells not working properly due to the mutation in ASXL1. What I generally would advise for constipation in children is making sure they drink enough fluid, and your doctor can tell you based on the weight of your child how much clear fluid your child should be taking in a 24-hour period, and making sure there's enough fiber in the diet. So again, this depends on the kind of diet your child is on, whether it is all liquid, whether there is some solid, and you can work with a pediatric nutritionist on how do you maximize diet intake. Now, it may be that your child will need some laxatives on a regular basis, whether it's Miralax, whether it's some other laxative, would depend on your child. So I think I would sort of defer that to your child's GI doctor. The last thing I'll say about constipation is that if your child had been constipated for a while, sometimes it is worth considering a bowel cleanout before you sort of institute a regular laxative regimen, dietary regimen, etc. Because if there are a lot of things that are sort of stuck in the colon, in the rectum, and it's all bunged up, then no matter what you pour in from the top, it's going to get stuck. So you really want to open up and clear that whole passage, if you like, before you start having a regular regimen. Physical activity will also help. So for those of you who have children who are ambulatory or somewhat ambulatory, are able to walk, moving around, that again helps the bowels to move. So those are the things I would sort of say about constipation. I don't know if Dr. Ross has anything to add, but.
Great, thank you. We're going to move on to the next question, which is about sleep apnea. So do you have suggestions, Dr. Russell, for sleep apnea if CPAP is not an option?
Yeah, this is a really common challenge that individuals with BOS just don't tolerate CPAP. It has not gone well for many families that I've cared for as well. So I think it's really important that you work with your pulmonologist or your sleep medicine doctor and work to figure out other ways that you could optimize the sleeping environment, whether it's sleeping at a slant, head elevated, if there's ways to make sure that the airway is opened, if there was ways to monitor oxygen levels and supplement oxygen if needed. So work on alternative ways to try and optimize that, because this is a common challenge that CPAP is not something that's very well tolerated by most individuals.
Thank you. Next, a very timely question. What is your advice on the COVID-19 vaccine, particularly for younger children?
That's a really good question, and certainly timely. COVID-19 is something that's a risk for all of us, including our children, and any child that has other medical challenges theoretically may be at risk for more severe complications with the virus, though we don't have enough information to put out any papers at this point that say kids with BOS are at more risk than other children. So what I think Dr. Tan and I both encourage our families to do is to explore this with your doctors, but also that vaccinations have shown to be very safe and that the benefits of vaccination outweigh the risks. And that getting sick with COVID has more complications than what we see with the vaccine, and to sort of trust the science and the researchers that when the vaccine becomes available to children, the expectation is that kids with BOS should respond typically as well. The individuals we're seeing that perhaps do not respond typically to the vaccine are often people with underlying immunologic defects, so their immune system is not typical. We have not seen that be an issue in individuals with Bohring-Opitz syndrome. So we do not have any evidence or any reason to suggest that they would not respond as expected to vaccination.
And I would add to that, that it is really important that all caregivers, parents, other siblings who are eligible for the vaccine should absolutely get vaccinated as soon as possible. And when they lower the age limit, if your child is eligible, then absolutely go for it. But you know, people who come in to do therapies, parents, grandparents, older siblings, they should absolutely all get vaccinated as soon as possible.
Thank you. Next, we're going to go to another body system. We're going to go to the eyes and with an ophthalmology question. Could you speak a little bit about eye complications associated with Bohring-Opitz syndrome? Have you seen retinitis pigmentosa, dry eye, or myopia in Bohring-Opitz syndrome patients?
So myopia is the most common, and that's difficulty seeing far away. And this has been very well reported in the medical literature as well, that it's quite common for individuals to have pretty significant visual defects where it's hard for them to see far away. But we also find that it tends to improve with age. And I think some of this has to do with the general eye shape of a lot of individuals with Bohring-Opitz syndrome. There's often a lot of prominence to the eyes, and the eye globes tend to have a very prominent sort of rounded shape. And as a child grows, that shape actually changes and adjusts, and we see that that myopia tends to actually improve. When you really have an ophthalmologist looking at the back of the eye, we do note optic nerve changes at the back of the eye and some other smaller things that don't typically impact the function of the eye, at least to any degree of significance. Retinitis pigmentosa is not something that I've been aware of in any individuals I've cared for, or anything that I know of from the literature. So that's not something that we've seen as far as I know. And then dry eyes also is sort of along the shape of the eye and the eyelids. So if the eyelids are not closing completely, particularly at night when sleeping, that can really cause irritation and dryness to the eyes. So there are things that can be done, like actually putting things like Vaseline over the eyelids at night when you're going to sleep, if you're noticing that your child's eyes are opening or not closing completely. So there are some things that you can talk to your eye doctor about to help protect for dry eyes as well.
Thank you. So next question, we've talked about ophthalmology, neurology, gastroenterology. Let's talk about the whole team. Who do you need to have on your medical team to provide care to someone with Bohring-Opitz syndrome? And Dr. Tan, we'll start with you.
So I think the most important person in the team is actually your primary care physician. And having a good primary care physician who can help you coordinate the various specialists your child needs to see is important. If you're fortunate enough to have a clinical geneticist, you can turn to that person can usually help with this coordination of different specialists as well. But I recognize that that's a privilege that's not necessarily afforded to everyone in the country, depending on where you live. What I would also say is that, yes, you do need to have specialists who are that will address your child's medical issues, but you do not want to over-medicalize any child. So if you have, for example, done an echocardiogram, a heart ultrasound, and your child does not have a heart issue, there's no reason to follow with a cardiologist. If your child has seizures, obviously he needs to see a neurologist. And if your child has feeding issues, then seeing a gastroenterologist would be important. In general, these are probably the two specialties that most children would need. And then depending on whether they have other issues as they come along, you can add to your team of specialists. But I would sort of go with having a clinical geneticist or primary care physician who can sort of help you monitor this periodically, and seeing that person every 6 months or every year to see how things are going and to reassess the physicians or specialists that your child would need to see.
I agree with everything Dr. Tan said, and to sort of circle back to actually the very first question, advocating for yourself and for your child is important. So finding providers that you feel comfortable with, and making sure that their advice makes sense. If something doesn't make sense to you and it doesn't work for you and your family, it's okay to get second opinions. It's okay to ask more questions, but make sure that whatever your team is recommending really does fit with you and your family and your goals of care. And it's okay to question your medical team.
Thank So next we're going to move to some stages of life questions here. So the next one is for Dr. Russell. What changes occur during puberty? Are there changes we should watch for in adolescence?
Okay, so puberty happens to all of us as we transition into adulthood. And I don't know of anybody that liked puberty, right? So it is not a fun time. It is all of our most awkward moments, those pictures that you just hang your head at and go, oh my gosh, I can't believe I chose to wear that out of the house. So, right. So puberty is hard for everyone, and it's just as hard for kids and individuals with Bohring-Opitz syndrome. So the hormones, the body changes, the lack of control of your emotions, all of these happen to all of us. And it's really important to remember that they're happening to your child as well. And what makes it even harder is that most young adults with Bohring-Opitz syndrome are not able to really communicate with us on the level of detail to express sort of their deeper emotions and their feelings, and they can become very overwhelmed by all the things that are happening to their body, not just physically, but the mental changes and the hormonal changes that happen to all of us when we go through puberty. So it's really important, I think, as a family, a caregiver, and a parent to remember this and try and have sort of some perspective that this is normal. So we expect there will be changes during puberty. There's often more behavioral issues. We see more outbursts. We see more agitation. We see more just overall frustration. It is something too that we've been watching in some of the patients that I've cared for as they're getting older. We have had some concern that there also may be psychiatric issues that develop. So a child with Bohring-Opitz syndrome can be depressed just like anybody else in the world. So it's really important to try and pay attention to those signs. If you think that your child is depressed and is not wanting to engage like they were previously, seeing a psychiatrist or somebody who can help diagnose that can be really helpful, as there are medical management tools for that as well. Also recognizing if you think that your child is seeing things that aren't there or hearing things that aren't there, those are also really important signs that it may be important to get an evaluation by a psychiatrist who is used to working with individuals who may be less communicative than a neurotypical individual. So puberty is hard for everyone. Nobody's going to get away with an easy puberty for any child that they have. But I think really trying to understand, you know your child best, trying to understand what's changing, recognizing that, and knowing that these things will hopefully be short term and that we all move through puberty and things stabilize after that period in our life. But recognizing that if there are concerns for things like psychiatric changes, that you are getting those evaluated and getting help for your child.
Great, thank you. And next question is looking to adults. So someone wrote with a question, my daughter is turning 33. Are there changes we should watch for in adulthood?
That's a great question. And unfortunately, we don't know a whole lot yet, except for to say that the few 30 plus individuals that we know of seem to be doing quite well. They continue to have the medical challenges that they've had throughout their life. But we aren't seeing anything like a decline or a loss of skills. It seems to be relatively stable as somebody progresses into adulthood. But again, we only have a few individuals in that age group. So it's something like the registry is really important so that we can understand what to expect into adulthood.
Great. So that's a great segue into our next set of questions, which are all more focused on genetics and research. So Dr. Russell, we're going to keep going with you, given that you lead the registry. So could you just give us a general update on research progress right now? What's happening? Where are we going? Are there any treatments on the horizon? And then specifically, a lot of families have questions about gene therapy as a potential treatment.
I would say it is a great time to be a geneticist. There is so much changing at the moment. There are so many exciting therapies being developed for conditions that we didn't even know existed 5 to 10 years ago. So it is a time of change and progress. So stay tuned overall. At the moment, we do not have any specific treatments, but it doesn't mean that those won't be developed in the future. The main focus at the moment is really building an interest in the research community in the ASXL disorders, trying to find basic scientists who are interested in these conditions and really have the tools in the laboratory set up to study it. There is a mouse model that exists, which is a really important tool for basic science researchers. So that is a really important way for us to study how the ASXL1 gene impacts the development, something that we're not able to do in people. So the mouse model is definitely there, and progress is being had into understanding how this gene impacts development. There is also a lot of work going on to try and understand how the ASXL1 gene changes your methylation signature. So basically, this gene is important for turning on and off the genes. So you think of your DNA as your instruction book. It tells your body how to do all the things that it does. But that DNA and that instruction book doesn't always get read in the exact same order every time. There are tools that our body uses to read only parts of the DNA at different parts of development and in different parts of the body. And so what we know so far about this gene is that it's not always turned on, and it's turned on and off at different times. And it also goes out and turns other genes on and off at different times in our body's development and function. So some of our collaborators are working on understanding that pattern and trying to develop a tool to actually look at the downstream effect of this gene. And that's something that's very powerful in trying to find therapeutic targets. So medications that may be able to act on some of these genes that get turned on or turned off, and changing that pattern. If a gene is turned off and it should be turned on, can we go back in and turn the light switch back on? That's a really powerful tool and something that we really want to learn more about. So I think we are on the precipice of some really exciting things, and our research network is really expanding in an impressive and very exciting way. Gene therapy is very exciting and something as geneticists that we're all chomping at the bit to get out there for everybody. What I will say is that so far, gene therapy has been working very well in conditions where there is a single organ involved. So the liver or the eyes, we've been able to do gene therapy that's targeted just at that one part of the body. We have not yet been quite so successful in doing gene therapy for something that affected the brain and the body during development, so prenatally, when the baby was being formed. We have not been as successful yet in determining how to get that into the body and have the body accept it and then cause a significant change. So we still have a ways to go, but it's certainly something that we're looking forward to. When it comes to what Dr. Tan and I are doing in the registry and the biobank, this is a really, really important and valuable tool. The registry collects basic information about the medical histories of individuals with Bohring-Opitz syndrome. And this is important for us to answer all the questions you've already asked today and have us understanding of what to expect and what can be seen in this condition. And the biobank is a way for us to collect samples from all of you in order for these researchers to have the tools that they need to really understand how this gene works and really work on therapeutics and treatments that can have an impact. So it's a multi-site study. UCLA is the main site, but Dr. Tan at Boston Children's is also a site and can enroll families, as well as our colleagues at Cincinnati Children's and at Duke. So it really is a multi-site study, and wherever you live, there is an opportunity to be involved as well.
Thank you. So Dr. Tan, next question is for you. Can Bohring-Opitz syndrome be detected prior to birth? And is there a risk to future pregnancies? And I'll also tack another question that just came through the Q&A about newborn screening. Is there an opportunity to add screening to Bohring-Opitz syndrome into the panel of newborn screening?
Okay, so there are a few different components to this question. Standard prenatal ultrasound or imaging would not detect Bohring-Opitz syndrome because there are no structural abnormalities that can be seen prenatally. The exception, of course, being that if your child has a cleft lip or cleft palate with ultrasound, or more likely with fetal MRI, if available, you can pick that up. However, there are literally thousands of genetic conditions associated with cleft lip or cleft palate. So, and Bohring-Opitz syndrome being just one of these hundreds of conditions that can be associated with it. So there's no reason for someone to think of something so rare if they see a fetus with cleft lip palate. So the simple answer to can prenatal screening detect Bohring-Opitz syndrome is no. Now, if there is a family history, if you have had a child with Bohring-Opitz syndrome in the past, and you're worried about having another child with Bohring-Opitz syndrome, you can do an amniocentesis, so you take some fluid out from the uterus, or do a coronary villus sampling, a CVS, and test specifically for that mutation, Bohring-Opitz syndrome mutation you're worried about, or that gene, and you certainly can detect that prenatally that way. In terms of newborn screening, right now there is no easy way to screen for that. There are no newborn screening programs for Bohring-Opitz syndrome. In order for a particular genetic condition to be screenable for newborn screening, or to be included in newborn screening, one of the criteria is that there needs to be treatment, and the treatment needs to be effective or more effective if initiated early on, so right after birth. And right now we are not ready for that in the Bohring-Opitz syndrome. So one day if we have therapy and we can show that therapy works better if administered early, then we can think about newborn screening.
Thank you. All right, we're going to go back to some of the questions from the chat here. So Dr. Russell, a question about the registry. For folks who live outside of the US, is it possible for people to send samples, so blood or the skin biopsy samples from outside the US? And if so, how would one coordinate that?
Yeah, we are trying. I will say that it is a large effort, and it does not work with every country, and the pandemic has made that even harder for us. So we have some tools to try to do that. I'll say that we have not successfully been able to do it, but we are always up for trying, and we would love to hear from you. So the first thing is to email the registry email, and we will work with you and figure out the best way and how we can do this. So we encourage everyone to contact us, and we will do our very best.
Thank you. And Elena can put in the chat the email address again, which is that will go to the right person on Dr. Russell's team who can answer those specific questions for you. So let's see, let's do another question. So we have several genetic counseling students who are sitting in on today's session. And the question is, I'm curious what you see as the role, if any, of a genetic counselor being in the diagnosis and care of individuals with BOS or other ASXL syndromes.
Yeah. Oh, welcome. That's great to hear. I'm so glad that you're interested and that you're here, and hopefully maybe you're caring for individuals with Bohring-Opitz syndrome. Absolutely. Counselors are an incredibly important part of the genetics team. They have additional skills that some of us geneticists lack or are not as good at, in being able to communicate well with families, understanding some of the nuances of how to help support families, and navigate the medical system. And so I think genetic counselors play a critical role in helping to make sure that individuals with Bohring-Opitz syndrome get the best care that they can get. So I'm glad that you're here.
Thank you. Okay, next question. We're going to go back to sleep. So what ways can we help regulate our children's sleep? This person says their child has never had a regular sleep pattern.
This is incredibly common. It's one of the, I would say, probably the biggest challenges that families report to me, because we all need our sleep. And so it's very difficult when someone in your household is not sleeping as they should. And, you know, I am still looking for the magic pill that's going to fix this. I think that it's not uncommon for individuals who have a neurocognitive condition to have a atypical sleep pattern. Some families do find benefit from melatonin. Sometimes it works sometimes and not other times, but it is something that's always sort of the first recommendation. Good sleep hygiene and sleep patterns, easier said than done, and also not always beneficial, but definitely a good starting point. The other thing I will tell some families is that it may be that your child doesn't need as much sleep as other children do. And so I have some families who say, my kiddo was up all night, but you know what? In the morning, they still participated in therapies and they did just fine. And my answer to that is, then that's okay. But I have other families who say, my child didn't sleep at all last night and now I can't get them out of bed and they're grumpy and angry and this is miserable. So I specifically target trying to get more medications and therapies involved if somebody is really impacted by their atypical sleep pattern. There are specialized clinics that specialize in sleep and specialize in sleep in individuals with neurocognitive conditions. So if you have access to a clinic like that, that would be where you'd go. Also developmental pediatricians and neurologists are other places where they may have medications that you can try to help your child go to sleep and stay asleep. But unfortunately, this is a big challenge that we don't have a perfect solution for.
And a follow-up question just came through. Could you speak a little bit about using CBD as a potential option for helping children with sleep?
Yeah, so CBD is really interesting. It is something that definitely a good number of families have reported to me that their child has found benefit from. I've also had other families that tried it and said this just didn't do anything for us. So I think the response is variable. You need to find a provider who is comfortable with CBD and understands it and can work with you to find the right formulation that would help with sleep and that would be a good fit for your child. So it is one of those sort of medications that you do need somebody who has some expertise to help you with. That is always my recommendation, as opposed to just sort of going and buying it and trying on your own, is really getting someone who can help support you with that. But that is something that some families have found benefit from.
Thank you. And so on the other end of the spectrum, we have another question. So there are kids who have trouble sleeping, but what about kids who will sleep for days or weeks without waking?
Yeah, I think this all fits within the spectrum of what we see, and that there's often some sort of cyclic nature to it where they will be up for days and days and days, and then they'll crash and be out and asleep for days on end. And again, it has to do, I think, with the brain not regulating the circadian rhythm, so that typical wake sleep cycle as well as it should. So if this is something that is impacting your life and your child's life, then again, I think seeing a specialist that can help try and regulate that would be important.
Thank you. And folks are welcome to put questions in the Q&A. We do have time to take some additional questions. So I'm going to go to our last question that was pre-submitted, and then we can take some more questions live. So if you have questions for Dr. Russell and Dr. Tan, now is a great time to put them in the Q&A box, and we can try to get to them. So the next question is about research into ASXL1. And if you do a survey of the literature, just Google ASXL1 research, you'll find research related to cancer. So why is this cancer research different from mutations related to Bohring-Opitz syndrome? And should this be an area of concern for families with an ASXL1 mutation?
Mm-hmm. So Let's go back to sort of the basics of what happens in cancer versus what happens in someone who has a neurodevelopmental condition. So in individuals who have Bohring-Opitz syndrome, they have a change in the ASXL1 gene that is present at conception. So egg and sperm come together and that change is present. And then every cell in the body has that change within it, and that impacts how the body and the brain develop. What's different is in cancer, in an individual who has cancer and has a change in the ASXL1 gene, that ASXL1 change happened just in those cancer cells. And so when that person's body was creating a cancer for whatever reason, it developed this change in the ASXL1 gene. And if you think about what cancer is it's an abnormal growth of cells of some part of the body. And if you think about what ASXL1 does in the body, it's a growth gene, right? It's important in the neurodevelopmental process. It's important in how the body and the brain forms. And so in a cancer process, cancer cells would benefit from growing too much. That is what they're trying to do. So cancer cells have found a way to sort of harbor this ASXL1 change because it makes them work better, okay? And so those are two extremely different processes, and they have very, very different impacts. One is the cancer process, and the other is in the development of the body. We've discussed that we do see an increased risk for Wilm's tumor, and we have one individual with hepatoblastoma. We have not seen any other forms of cancer in the registry. And it is something that we will keep watching. And somebody else had sort of asked about older individuals in their 30s and beyond. This is a relatively new condition, so we don't have a lot of adults. So it is something that we'll keep a close eye on. But that being said, there are a lot of neurodevelopmental conditions that are related to early growth and development that also have a counterpart in the cancer side because of what these genes do. And we do not see overall an increased risk for cancer in the neurodevelopmental side. So again, this is something that we are certainly aware of and we're watching. And in fact, it actually may be a very good target for treatments for Bohring-Opitz syndrome. So it's actually something that is potentially exciting to us. And we have not seen the increased risks for cancer that you might be worried about. Okay.
Thank you. So another question is, and perhaps maybe this is a question to answer from the perspective of the registry, Dr. Russell, and what you've seen there. Is there a pattern in primary causes of death in people with Bohring-Opitz syndrome? And are there any preventative measures that can be taken to mitigate some of those risks?
So we have very few individuals in the registry that have passed on. So that is certainly an area where we would love to recruit more participants. As you can imagine, that is a challenge of ours. What we see is that there are sort of two different peaks in individuals that pass away. There is a larger sort of early peak in that there are some children who are born with very severe complications, things that are involving the heart or the brain or the digestive tract, and are so significant that the child does not survive past 1 year of life. So we do know that there are certain individuals who do not survive past 1 year. But those that do survive past 1 year of life, which is at this point the majority of individuals, thanks to sort of modern medicine and all of the families, and those individuals tend to do quite well. We do see some who've passed away from complications related to seizures, one who did have a twisting of the gut, as I mentioned, and some that have had sort of difficulties with their heart beating quick enough. So what we call bradycardia, or low heartbeats, and basically the connection between the brain and the heart and making sure that the body is working as it should. So those have been the causes, but those are by far and away less common. We only have, I think, less than 5 individuals in the registry who have passed on. But again, there's sort of those two peaks where it's rare, but possible to pass on after 1 year of life. And then there's more common causes of individuals who passed away before their first birthday.
Thank you. And Dr. Tan, I think you wanted to take a question about if there's increased risk for Bohring-Opitz syndrome for the offspring of siblings of individuals with Bohring-Opitz syndrome and the recurrence risk.
Yes. So, well, in the vast majority of instances, the mutation that results in Bohring-Opitz syndrome, so the ASXL1 mutation, is a new spontaneous mutation that happens around the time of conception, and as I emphasized earlier, has nothing to do with what either parent did or didn't do during the pregnancy. We have also found both in Bohring-Opitz syndrome and actually also in the other ASXL disorders, that there is an increased risk of this mutation happening again spontaneously in some unknown proportion of the eggs or the sperms. So this is a phenomenon called gonadal mosaicism or germline mosaicism. And what it means is that if you were to sample the sperms in the father or the eggs in the mother, that of children who have Bohring-Opitz syndrome, in a very small proportion of these cases, there is this mutation is actually present in some small but unknown proportion of these parents. The implication is that the risk of a parent having another child with Bohring-Opitz syndrome is higher than what one would expect if the parents have never had a child with Bohring-Opitz syndrome. So, and this is something that you can test for prenatally during the pregnancy. So I would suggest that for any parent with a child with Bohring-Opitz syndrome thinking of having another child, then you should talk to your OB or a prenatal genetic counselor to think about testing if you're concerned. We certainly know of a few families where they have had more than one child with Bohring-Opitz syndrome. So now, in terms of other siblings of children with Bohring-Opitz syndrome, no, they are not at risk of having children with Bohring-Opitz syndrome themselves, because if they had Bohring-Opitz syndrome, obviously you would know about it. If they did not have Bohring-Opitz syndrome, it tells you that they did not have the mutation in the ASXL1 gene, and there's no reason for them to pass that on. So their risk will be no different from the risk of anyone else in the general population, and obviously there is a risk of anyone has a risk of having a child with Bohring-Opitz syndrome. And I hope that answers the question.
Thank you. So the next question is related to pain management. What would you recommend for pain management when Tylenol and Advil don't seem to help? This is while trying to deal with the underlying cause, which is constipation or gas, but that can't be resolved overnight. So we need to find a pain management solution for the interim. Do you have any suggestions there?
Yeah, so just like you would with any other child, that some things like distraction can work. It sounds a little bit crazy and trite, but think of other things, and your child really feels what you feel too. So if they can tell that you are anxious or upset about something, they may be channeling that feeling too. So thinking of other things that your child enjoys. Can you go for a walk? Is there a television program that they tend to enjoy? How can you help them sort of work through what they're feeling? Other things like that we often forget are things that are hot or cold, right? So depending on what the pain or the injury may be, sometimes hot and sometimes cold things can help. Even things like gentle massage can help too. So some of those sort of things are important to still remember for your child. When it comes to stronger medications, things like opioids and pain medications have their own complications to them. And those would not be things that I would recommend without significant oversight and support by your doctor. But obviously, if you think that there is more severe pain, then there should be presenting to the emergency room or going in to visit your doctor does make sense as a next step as well.
Thank you. And next question is about the registry. How many families are in the registry currently?
Great question. For the ASXL1, so for Bohring-Opitz Syndrome, I believe we have around 70, 75 families who are enrolled. And then overall, I would say we have probably around 115, 120 families in the registry for the 3 conditions.
Thank you. All right, well, that's all we have for live questions here. So want to thank you both for your time this morning. Really appreciate it. And we got to a lot of questions here. So I'm going to close with just a few final slides here, and then we'll wrap up for the day. Awesome. So I just want to say thank you again to Dr. Russell and Dr. Tan, and for sharing your time and your expertise. We're very grateful, and they've been with the R Foundation from the very beginning. So we're very grateful for all of the guidance and expertise that they've provided to us as an organization, and also to families as well. So as we close, I do want to invite you to connect with us. We do publish a monthly newsletter and announce events like this one through our email list, and you can sign up for that on our website. And of course, I also invite you to follow us on Facebook, Twitter, and Instagram. We share a lot of good resources there as well. And also want to just invite you again to feel welcome to connect with us as far as getting involved with us from a fundraising perspective or volunteering. And again, my email is there if you have questions about that. And there's also information about all of those opportunities on the website as well. So in closing, just want to say thank you to everybody who made time to join us today from all over the world. You will receive a link to a survey tomorrow that will come on an automated message to share your feedback on today's session. We base our programming on family feedback, so please take a moment to share your thoughts about today's program, and you can also suggest topics for future sessions as well. And finally, at the conclusion of this webinar, you'll be taken to our donate page. And if today's session was helpful to you, I invite you to help make a contribution to support future programs like this one. So thank you again to everybody who joined us, our panelists, Elena for her help, and everyone who attended from around the world today. Thanks, everybody.